Welcome to the Deep Dive. Today we're jumping into the amazing mechanics inside your body, stuff you don't usually see.
Yeah, we've got these rapid revision anatomy notes here.
Exactly. And the mission is, well, to give you a quick way to grasp the basics, how you move, how your blood flows, what holds you together.
Kind of a shortcut to understanding your own physical self.
Prepare for some real aha moments about the engineering under your skin. Okay, let's unpack this first big topic, joints.
Right.
It's easy to just think, knees, elbows, but there's this whole spectrum, isn't there? From almost rigid to super flexible.
Absolutely. And that diversity is key to function. We usually classify them by how much movement they allow. So first up, you have fibrous joints. The technical term is synarthrosis.
Synarthrosis.
Yeah, think together joint. They're bound by tough fibrous tissue, so there's a very little or even no movement.
Like in the skull, those zigzag lines.
Precisely. The sutures between your cranial bones are a perfect example. Or even where a tooth sits in its socket, that's called a gomphosis. They're built for stability, basically.
Got it. Super strong, don't move much. What's next?
Next are cartilaginous joints, or amphiarthrosis. That name kind of hints at limited flexibility on both sides joint.
Okay.
Here, bones are linked by cartilage, so they allow some movement, but not a huge amount.
Like your spine, the discs between the bones.
Exactly. The intervertebral discs, they let your spine bend and twist a bit, plus they absorb shock. Another neat example, especially if you're still growing, are the epiphyseal plates.
The growth plates.
Yeah, those temporary cartilage joints in long bones that let them get longer before they eventually fuse.
Fascinating. And the third type, the really mobile ones.
Right, those are the synovial joints, or diaphysis. Through joint, meaning they allow free movement. These are the most common. Their defining feature is a joint cavity filled with synovial fluid. That's what allows the freedom of movement. Think of your hip or shoulder, those ball and socket joints.
Huge range of motion there.
Definitely. Or your elbows and knees, the hinge joints, allowing for that back and forth flexion and extension.
That makes sense. A great overview of how we're connected. But all that movement needs fuel, right? Which brings us to the circulatory system. This is where it gets really interesting for me.
Yeah.
The difference between the vessels carrying blood away from the heart and those bringing it back. What's the core engineering there?
Ah, okay. If you look at the body's plumbing, arteries and veins are quite different. Arteries carry blood away from the heart.
Away. Got it.
And they're under high pressure from the heart's pump. So their walls are thick, muscular, and elastic. Especially that middle layer, the tunica media.
Why so thick? Just to handle the pressure.
Well, yes, but it also helps regulate blood flow and pressure. It acts like a dynamic shock absorber. And their internal channel, the lumen, is relatively narrow. That contributes to the pulsatile flow, the pulse you can feel.
Right, okay. And veins are the opposite journey.
Completely different job, yeah. Veins carry blood towards the heart. They operate under much lower pressure.
So thinner walls.
Significantly thinner walls, yeah. And the lumen is wider, often looks kind of collapsed. The really critical feature, though, especially in your legs and arms, are the one-way valves.
Valves.
Yeah.
To stop blood flowing backwards.
Exactly. They prevent backflow, especially against gravity, ensuring blood keeps moving towards the heart. This means the flow in veins is non-pulsatile, much steadier.
Okay. And how does this relate to common problems? You mentioned applied anatomy.
Good question. So take atherosclerosis, hardening of the arteries. That affects arteries. Plaque builds up inside in the tunica intima, narrowing those crucial pressure-bearing vessels.
Okay, so it directly impacts that high-pressure system.
Right. Whereas varicose veins, that's a vein problem. It happens when those one-way valves fail, become incompetent. Blood pools, and you get those swollen, twisted veins, usually in the legs.
Wow, okay. Different structures, different problems. Now, let's shift gears slightly. From blood flow to... well, what actually connects muscles to bones and bones to other bones? Tendons and ligaments.
Yes, the body's ropes and cables.
We hear those terms all the time, especially with injuries. But what's the precise difference?
Okay, so tendons. Think T for transmit. They are dense connective tissue connecting muscle to bone. Their main job is transmitting the force from your muscle contractions to your bones. That's what creates movement.
So when I flex my bicep, the tendon pulls on my forearm bone.
Exactly that. They need incredible tensile strength. Now, ligaments, think L for link. They're also dense connective tissue, but they link bone to bone.
Bone to bone, okay.
Their role is primarily stability. They support joints, kind of like guide ropes, and limit excessive or unwanted movement. They stop things from dislocating or twisting too far.
So tendons move things, ligaments stabilize things.
That's a great way to put it. And knowing that helps understand injuries. Tendinitis, that's inflammation of a tendon, often from overuse, like repetitive strain causing micro damage.
Makes sense.
A ligament sprain is an injury to a ligament. Maybe a sudden twist stretches or tears those stabilizing fibers.
Ouch.
Yeah. And something like shin splints often involves inflammation of the tendons and muscles attached to the tibia, again, usually an overuse issue, shows how these tissues work together but can be pushed too hard.
What an absolutely incredible system. It really is astonishing when you stop and think about the design.
Yeah.
From, a skull suture that barely moves to the vital job of arteries and the way ligaments just hold everything steady.
It really is. And if we connect this to the bigger picture, just understanding these fundamental bits, the tiny fibers, the different joints, the way blood flows, it gives you such a deeper appreciation for the amazing engineering, the delicate balance that lets your body work often silently every single day.
The silent choreography, that's a good way to put it.
So maybe the thought to leave with is, what part of this incredible hidden machinery stands out most to you when you consider your own body just quietly doing its thing? Welcome to the deep dive. So today we're taking this really fascinating journey deep inside your own body. We're zooming right into the microscopic worlds of four incredibly vital organs: the pancreas, liver, testes, and kidneys. Our mission for you is basically to uncover the hidden cellular workings that make them tick and understand what happens when things go wrong, giving you a kind of shortcut to appreciating just how complex they are.
Exactly. And it's not just, memorizing biological terms. It's about seeing the sheer elegance of the design at this tiny scale. These structures, they're really the foundations of how your body stays in balance, working constantly behind the scenes.
Okay, right. Let's unpack the first one, the pancreas. I think most people know it for insulin, but it really is a multitasker, isn't it? I was reading about these pancreatic, they're like tiny pyramid-shaped factories, right? Pumping out powerful digestive enzymes like amylase, lipase.
Yeah, the ones that break down carbs and fats. It's incredibly efficient, that dual function. And it highlights how problems there, like in pancreatitis.
Oh, right, where it gets inflamed.
Precisely. The enzymes essentially start digesting the pancreas itself. It shows that razor-thin line between function and, self-destruction.
Wow. Okay, so that's the exocrine, the digestive part. What about the hormone side?
Right, the endocrine side. So scattered throughout the pancreas, you've got these little clusters called the islets of Langerhans, like tiny islands. And that's where you find the famous beta cells making insulin.
To lower blood sugar.
Exactly. And the alpha cells making glucagon to raise it. It's just amazing how critical these tiny cell clusters are. When we think about diabetes mellitus.
Yeah, that's destruction of the beta cells, isn't it?
Directly. It really makes you think, how can such a small group of cells have such massive control over your whole metabolism?
That's a great question. Okay, from that delicate balance, let's move to the liver. The body's like chemical plant, you said. I picture these tiny hexagonal units inside, the lobules, each with a vein in the middle. And at the corners, you have these portal triads. Sounds important. An artery, a vein, and a bile duct all working together. It's this really sophisticated setup for processing everything you eat and drink. So what happens when the system starts to fail?
Well, within those lobules, between the plates of liver cells, the hepatic cords, you have these wide, sort of capillary-like vessels, sinusoids, and they're packed with Kupffer cells. Think of them as the liver's own immune cells, macrophages cleaning everything up.
Okay.
But the thing is, the liver's ability to regenerate its resilience can also be a problem. Chronic damage leads to cirrhosis.
Scar tissue, right?
Exactly. Fibrous tissue replaces the healthy stuff, messes up the structure, and disrupts blood flow. That causes portal hypertension, dangerous pressure buildup. It really shows how function can become dysfunction, tragically.
Okay, wow. So speaking of specialized functions, let's pivot to the testis. An incredible piece of cellular engineering for reproduction. The key structures are the seminiferous tubules. That's where sperm creation, spermatogenesis happens. But it's not just the sperm cells themselves, is it? There's support involved.
Oh, absolutely. Inside those tubules, you've got Sertoli cells. They're large columnar cells, kind of like nursemaids, providing structure and nutrients for the developing sperm. And then between the tubules, in the interstitial tissue, you find the Leydig cells.
They make testosterone.
That's right. They're the endocrine cells producing the key male hormone. And this brings up an interesting point, cryptorchidism. undescended testis.
Yeah, why does that cause infertility?
It perfectly highlights how critical the environment is, specifically temperature. These processes need things to be just right to work.
Fascinating. Okay, last stop. The kidney, the ultimate filter. The nephron is the key unit here. It starts with the renal corpuscle, which is like a tiny filter ball, the glomerulus tucked inside Bowman's capsule.
Collecting the initial filtrate.
Then that liquid goes into this long, winding renal tubule. The cortex, the outer part, has the filters, and the medulla organizes the loops and collecting ducts. It sounds incredibly organized.
It is, and that elegant design is completely tied to its function. The precision is just, well, astounding. Think about glomerulonephritis, inflammation of those tiny filters, the glomeruli.
That would clog things up, surely.
Exactly. It seriously impairs the kidney's ability to filter blood. Or consider acute tubular necrosis, ATN.
Damage to the tubules.
Right, that can cause acute kidney injury. It really underscores how delicate this whole microscopic filtration process is.
So we've really zoomed in today, haven't we? From the pancreas doing double duty to the kidneys filtering constantly. It's genuinely amazing how these intricate cellular setups underpin such vital functions in your body. Hopefully you've got a clearer picture now of how these sort of hidden worlds contribute to your overall health.
Yeah, and what's really striking isn't just the individual parts, but how interconnected it all is. Every microscopic detail we touched on is like a tiny essential cog in the machine of life. You know, considering how incredibly specialized and frankly delicate these structures are, it poses a fascinating question. What does that tell you about your body's capacity for healing and adaptation, even when tiny parts get damaged? Something to keep exploring.
Welcome to the deep dive. Today, we're going microscopic, looking inside your own body. We're focusing on three, well, foundational bits: the spleen, cartilage, and epithelial tissue. Our mission: to really give you a clear, sharp understanding of how these tiny structures do, massive jobs for your health. Think of it as a shortcut to understanding yourself.
Exactly. And it's not just the mechanics, it's about why it matters.
Yeah.
We'll connect these building blocks to your health and even some common medical conditions.
Yeah, so let's jump in. The spleen. Okay, let's unpack this. It's often overlooked, isn't it? But it's doing double duty.
It's this immune system center and a really clever blood filter.
Yeah, and what's wild is, it's important, but your body can technically manage without it, with some trade-offs, obviously, for immunity. How does that work?
It's all about its internal setup. Microscopically, you see two main zones. You've got the white pulp.
Oh, wow.
That's basically lymphoid tissue packed with lymphocytes, clustered around blood vessels. It's your immune response zone in the spleen.
Got it. Immune central.
Then there's the red pulp. Lots of blood-filled channels and cords of tissue. Its main job, filtering, pulling out old or damaged red blood cells.
So that's the filter part.
Precisely. And when things go wrong, like with certain infections, you might see splenomegaly, the spleen gets enlarged because it's working overtime, either fighting something or clearing out more cells.
Makes sense.
And if someone needs a splenectomy, removal of the spleen, they lose that filtering capacity and a big chunk of that specific immune function. That can make you more vulnerable to, well, certain types of bacterial infections.
Okay, from the spleen's processing power, let's shift gears. Let's talk cartilage.
Yes, cartilage.
That specialized connective tissue made of cells, chondrocytes, right? Sitting in this matrix. And the really key thing, which makes it so hard to heal, is it doesn't have its own blood supply.
Exactly. That's the crucial point. It's avascular. No direct blood vessels, which is great for making it smooth and strong for joints, but terrible for repair if it gets damaged.
Right. Explains why things like a torn meniscus are such a problem.
Absolutely. And we see three main types, each engineered for its job. There's hyaline cartilage.
The most common one.
Yeah, the smooth, almost glassy stuff on the ends of bones in your joints. Think low friction movement. Then fibrocartilage. This is tougher, packed with collagen, great for shock absorption, like in your spinal discs.
Okay, like shock absorbers.
And finally, elastic cartilage. Lots of elastic fibers, so it's flexible like your external ear. You can bend it.
Oh, right.
So when this breaks down, maybe the hyaline cartilage in osteoarthritis, or you tear fibrocartilage like a meniscus in sports, it's a big deal because of that specific structure and, well, the lack of easy repair.
Fascinating stuff. Okay, now for something really versatile. Epithelial tissues.
Oh yeah, the body's linings and coverings.
Everywhere, right. Skin, organ linings, they seem to change shape and structure depending on the job.
They absolutely do. It's all about form following function. We classify them based on layers. Single layer, simple, often for absorption or secretion. Multiple layers, stratified, mostly for protection.
And shape, too.
In shape, yes. Flat cells are squamous, cube-shaped or cuboidal, and tall ones are columnar.
Can you give some examples? Like, where do we see these?
Sure, think about your lungs, the tiny air sacs, alveoli. They need super fast gas exchange.
Yeah.
So simple squamous, one thin flat layer. Perfect.
Makes sense. Thin equals fast fusion.
Exactly. But then your skin's outer layer, the epidermis, that needs to be tough. So stratified squamous, many layers of flattened cells for protection.
Okay. Tough outer shell.
Or the lining of your trachea, your windpipe, that's pseudostratified, ciliated columnar, looks layered but isn't quite, and has cilia, little hairs, to sweep mucus.
Ah, the mucus escalator.
Kind of, yeah. And even your bladder lining transitional epithelium, it can stretch out as the bladder fills, then recoil. Really unique.
Wow, okay, so they're incredibly adaptive. But you mentioned stress. Can that adaptability go wrong, become a sort of double-edged sword?
That's a really important point. It brings us to something called metaplasia.
Metaplasia.
Yeah, it's where one type of mature epithelial cell changes into another type. It's usually a response to chronic irritation or stress.
So the tissue changes its nature.
In a way, yes.
Right.
The classic example, unfortunately, is in chronic smokers. The normal pseudostratified ciliated columnar epithelium lining their airways, the one with the cilia,
Yeah.
can transform into stratified squamous epithelium. Like the skin type, it's tougher, trying to protect against the smoke irritation.
But it's not supposed to be like skin there.
Exactly. It's tougher, but it loses the cilia. So you lose that cleaning function, mucus builds up, and that change itself can be a step towards more serious problems down the line. It's the body adapting, but sometimes adaptations have risky consequences.
Wow. What an incredible journey through just three, fundamental parts of us. The spleen's filtering, cartilage's structure, the adaptability of epithelial tissues. It really highlights the amazing design.
It really does. And thinking about that adaptability, especially metaplasia, how tissues can literally change type under stress. It does make you wonder, doesn't it? Well, how might this built-in flexibility, this capacity for change within your tissues, present both unique challenges, but maybe also opportunities when we think about long-term health and how we recover from injury or illness?
That's a deep thought to end on, something definitely to consider as you explore the complexity inside you. We hope you enjoyed this deep. Welcome to the deep dive. Today we're peeling back the layers on your chest cavity.
Right. Going beyond just the heart and lungs people usually think of.
Exactly. It's this, hidden world under your ribs. We've got some anatomy notes here, and honestly, some of the connections are pretty surprising.
They really are. The engineering in there is quite something. Our mission today is to explore that architecture.
Show how these bits you don't normally think about are absolutely crucial.
And how interconnected it all is. A tiny issue in one spot can, cause big problems elsewhere.
It's a delicate balance.
Okay, let's start central. The command center, maybe? The mediastinum?
Good place to start. Yeah, the mediastinum. It's basically the central compartment in your chest.
Tucked between the lungs.
Precisely. Between the two pleural sacs. And here's the kicker. It holds all the thoracic organs except the lungs themselves.
Yeah, okay, so it's packed.
Very packed.
So.
And it's divided up. You've got the superior part running down to about the level of your second rib, the sternal angle.
That ridge you can feel on your chest bone. That's the one. Below that is the inferior mediastinum, and that splits again anterior, middle, and posterior sections.
Like different zones. What's in these zones?
Well, the superior part has the big pipelines, the arch of the aorta, other great vessels, your windpipe or trachea, the esophagus.
Okay, vital stuff. And the middle?
That's heart territory. The heart and its protective sac, the pericardium.
Makes sense. Central location for the heart and posterior.
More esophagus and the thoracic aorta running down your back. Important nerves too.
So you listening, imagine this crowded space. If something like a tumor grows there,
it can compress things very quickly. Nerves, airways, blood vessels.
Leading to symptoms, maybe shortness of breath or a cough that won't go away.
It really highlights how vulnerable that central corridor is. Everything's tightly packed.
That interconnectedness, it's key for just, breathing, which takes us to the diaphragm.
Ah, the diaphragm. The unsung hero, maybe.
Definitely. That big dome-shaped muscle separating your chest and your abdomen.
Musculofibrous partition, technically, but yeah, big dome of muscle.
And it's got that great mnemonic for its nerve supply. I think I remember this one. C3, 4, 5.
Keep the diaphragm alive, yes. The phrenic nerve comes right from the neck. C3, C4, C5, spinal segments.
Amazing how that sticks. And its main job is just breathing in.
Pretty much. It's the main muscle for quiet breathing. When you breathe in, it contracts, flattens down.
It's downwards.
Right, pulls down, increases the space in your chest, and air gets drawn into your lungs.
Simple but effective. But it does weird things too, right? Like hiccups.
Oh, absolutely. Hiccups are just spasmodic, involuntary contractions of your diaphragm.
Yeah.
Little glitches.
Yeah. And what about that weird shoulder pain thing?
Referred pain, yes. If something irritates the diaphragm, like maybe infection or inflammation underneath it,
Yeah.
you might feel pain way up in your shoulder tip.
Right there.
Seems random.
Because the phrenic nerve, C3 to C5, which supplies the diaphragm, those same nerve roots, C3, C4, C5, also supply the skin over your shoulder.
So the brain gets its wires crossed.
Basically, yes. It gets the pain signal from that nerve root and mistakenly thinks it's coming from the shoulder area.
Yeah.
Quite fascinating.
It really is. Okay, so diaphragm handles the breathing mechanics. What about the lungs themselves? They need protection, right? That brings us to the pleura.
The pleura, yes. Think of it as a two-layered wrapping paper for the lungs.
2 layers.
Yeah. There's the visceral pleura, which is stuck right onto the lung surface itself, smooth and shiny.
Okay.
And then there's the parietal pleura, which lines the inside of your chest wall, the diaphragm, the mediastinum.
And there's a space between them.
A potential space, yeah. The pleural cavity, it normally just has a tiny bit of serous fluid, like a lubricant.
So the lungs can slide smoothly when you breathe.
Exactly. Reduces friction. Now, the interesting part is the nerve supply.
Ah, right. You mentioned pain sensitivity differences.
Big difference. The parietal pleura, the lining of the chest wall, very sensitive. Pain, temperature, touch. It's got nerves like the ones between your ribs, the intercostal nerves, and the phrenic nerve again.
So if that gets inflamed, you feel it sharply.
Oh, yes. Pleurisy. That sharp pain when you breathe, that's the parietal pleura. But the visceral pleura, the one on the lung.
Let me guess, not sensitive.
Right. Insensitive to pain. It gets its nerve supply from the autonomic system, like the lung tissue itself.
Why the difference? Seems odd.
It makes sense functionally. You don't want to feel your lungs moving constantly.
Yeah.
But you do want an alarm system if the cavity lining is breached or inflamed.
Okay, that logic checks out. So, problems in that pleural space. Fluid buildup, air.
Yeah, common issues. Pleural effusion is when excess fluid collects in that pleural cavity.
Okay.
And a pneumothorax is when air gets in there, which can break the seal and cause the lung to collapse.
Right, a collapsed lung. And if there's fluid, you can drain it.
Yes, with a procedure called thoracocentesis, or pleural tapping.
Where do they do that? You have to avoid the lung.
Absolutely. Typically, it's done lower down and to the side. Usually the 7th, 8th, or maybe 9th intercostal space, the space between the ribs and the mid-axillary line, sort of under your armpit. That avoids hitting the lung or diaphragm, usually.
Wow. So much intricate detail in just this one area. We've covered the paced mediastinum, the powerful diaphragm, the protective pleura.
It really shows the elegant, complex design hidden away in there.
It does. All these parts working together, mostly unnoticed.
Until something goes wrong, perhaps. It makes you think, doesn't it? How much of our everyday well-being just relies on these hidden structures humming along perfectly?
Yeah, and maybe what can this complexity, this interconnectedness teach you listening right now about the subtle ways your own body might be communicating, even when you're not paying close attention? Something to ponder.
Welcome, Curious Minds. Today we're doing a deep dive into, well, some truly intricate designs inside your own body.
That's right. We're looking at the lungs and the heart today.
Exactly. Based on your sources, we're hoping to pull out some really surprising details about how they're built, down to the microscopic level.
And importantly, what happens when things don't quite go according to plan?
It's a quick mission. Uncover the most fascinating bits. Should be fun.
Definitely.
Okay, so let's jump right in with the lungs. First off, they're not identical twins, are they? Your sources point this out clearly.
Not at all. There's a definite asymmetry. The right lung, for instance, it's a bit shorter, a bit wider.
Because there's liver sitting right below it.
Precisely. And it's divided into 3 sections. Lobes, with 2 dividing lines or fissures.
Okay, 3 lobes, 2 fissures on the right and the left.
The left lung is different. It needs to make room for the heart, so it has this kind of indentation.
Ah, the cardiac notch. I've read about that.
Exactly.
Yeah.
So because of that, it only has 2 lobes and just the 1 fissure separating them.
Makes sense. But beyond that basic shape, what's going on inside? You mentioned the parenchyma.
Right, that's the functional tissue. And it's packed, absolutely packed, with millions of tiny air sacs, alveoli.
That's where the real action happens, the gas exchange.
That's it. And they're lined by these really specialized cells, 2 main types.
Type I and type 2.
You got it? Type I pneumocytes are incredibly thin, perfect for letting oxygen slip through into the blood.
Okay.
And type 2 pneumocytes, they make something called surfactant.
Surfactant. What does that do?
It's critical. It's sort of like a detergent. It reduces the surface tension inside the alveoli. Without it, they'd actually collapse when you breathe out.
Wow. So tiny cells, huge job. Which means if they're affected,
Then you run into problems, like pneumonia, which is essentially an infection inflaming those sacs, filling them with fluid.
makes breathing really difficult, obviously.
Terribly difficult. Or, lung cancer can actually start in those epithelial linings of the airways or the alveoli themselves.
Right. Okay, that's sobering. But there's also this amazing design feature you mentioned, the segments.
Ah, yes. The bronchopulmonary segments. This is really clever engineering by nature.
You describe them as sort of modular units, like apartments in a building.
That's a great analogy. Each lung lobe is further divided into these segments. And the key thing is, each segment has its own air supply, a tertiary bronchus, and its own arterial blood supply.
So they function somewhat independently.
Exactly. And that's incredibly important surgically. If you have a problem, say, an abscess, confined to just one segment.
You can remove just that segment
Right.
without messing up the neighborhood.
Precisely. You can resect that single disease segment, and the adjacent healthy segments just carry on working. It's remarkably efficient.
That's amazing. Okay, let's switch gears to the heart. The tireless pump. We know the 4 chambers.
Right atrium, right ventricle, left atrium, left ventricle, separated by grooves like the coronary sulcus on the outside.
And inside, the muscle itself has something unique. Intercalated discs.
Yes. These are special junctions between the heart muscle cells. They have gap junctions that let electrical signals pass incredibly quickly from cell to cell.
So the whole chamber contracts almost simultaneously.
Pow! Exactly. It ensures a coordinated, powerful beat. But, the heart muscle itself needs fuel. It's working constantly.
Good point. It's pumping blood everywhere else, but how does it feed itself?
That's the job of the coronary circulation, its own dedicated network of arteries and veins.
Okay, tell me about that.
Well, you have the main coronary arteries branching off the aorta. The right coronary artery usually takes care of the right side of the heart, and importantly, the heart's own pacemaker nodes the SA and AV nodes.
The electrical system controllers.
Right. Then the left coronary artery, that's a big one. It quickly splits. One major branch is the LAD, the left anterior descending artery.
The widowmaker. I've heard that term.
Unfortunately, yes. Because it supplies such a critical area, the front wall of the powerful left ventricle and the septum between the ventricles, a blockage there is serious.
And the other branch.
The circumflex artery, which wraps around to supply the left atrium and the side and back of the left ventricle. Then veins collect the used blood, mostly draining into the coronary sinus.
Which empties back into the right atrium to start this cycle again.
Correct. It's a complete dedicated loop just for the heart muscle.
Okay, one last thing that your sources mention, and it's always seemed strange to me. Referred pain. Why does heart pain, like angina or a heart attack, often show up in the left arm?
Yeah, it's a classic symptom, isn't it? It happens because of how our nerves are wired up.
How so?
The sensory nerves carrying pain signals from the heart enter the spinal cord at the same level specifically, T1 to T4, as the nerves carrying signals from the left arm and shoulder.
So the brain gets confused.
Essentially, yes. The signals arrive at the same processing hub in the spinal cord, and the brain isn't quite sure where the trouble signal originated, so it often interprets it as coming from the more commonly sensed area, the arm.
Fascinating. And understanding that is key for diagnosis, right? Like knowing arm pain could actually be angina.
Absolutely critical. And knowing that angina pain can often be relieved by drugs like nitroglycerin, which are vasodilators, they widen those coronary arteries.
So putting it all together, the lungs aren't symmetrical for a reason. They have this incredible modular design for repair.
The heart has its own fuel line, those amazing discs for coordinated beats, and this weird nerve crosstalk.
It really shows how intricately designed and well, interconnected everything is. Just amazing biological engineering.
It truly is. These systems highlight incredible efficiency and resilience designed to keep us going.
Hopefully this deep dive has sparked some aha moments for you listening.
Yes.
It really makes you wonder, doesn't it? What other hidden connections are shaping our health in ways we're maybe just starting to grasp? Welcome to the deep dive. Today, we're really getting under the skin, looking inside your chest.
Yeah, beyond just the obvious heart and lungs.
Exactly. We've been digging into anatomy notes, and our mission today is to explore that hidden architecture, these structures beneath the ribs.
Yeah.
You know.
The ones that are absolutely crucial, but maybe don't get the spotlight.
Right. We want to show how all these bits work together, this kind of silent ballet that keeps you alive.
It really is amazing when you look closely. It's packed so tightly in there. Every single millimeter counts.
Okay, so where do we start? Let's unpack this central command center you mentioned, the mediastinum.
Right, the mediastinum. So imagine your chest cavity. You've got the lungs on either side in their own sort of bags, the pleural sacs.
Okay.
The mediastinum is basically everything else crammed in the middle space between those sacs. It's surprisingly full.
Full of what exactly? You said everything but the lungs.
Pretty much. Your heart, the major blood vessels coming off it, like the aorta, your windpipe or trachea, your esophagus, it's all in there. From your breastbone, the sternum, right back to your spine.
Wow. Okay. And I remember seeing it like divided up. It's not just one big space.
That's right. It's neatly organized. We think of it as having a superior part up top going down to about the level of your sternal angle, that little bump on your breastbone.
Gotcha.
That superior part has the big aortic arch, the trachea, the esophagus passing through. Then below that is the inferior mediastinum.
And that splits even more.
It does, into anterior, middle, and posterior sections. The middle one is probably the most famous because that's where the heart sits, snug in its pericardial sac.
Ah, okay. And the posterior.
More esophagus, and the big thoracic aorta running down towards the abdomen.
So this is really important for you listening because, well, things can go wrong in such a packed space, right?
Absolutely, because there's basically no spare room if something like a tumor grows in the mediastinum.
It's going to press on things.
Exactly. It can compress the trachea, causing shortness of breath, or the esophagus, maybe difficulty swallowing, or even just a persistent cough. It really shows how interconnected it all is.
Yeah, no kidding. Okay, so the mediastinum is like the protective housing. But what's actually doing the heavy lifting for breathing? That takes us to the diaphragm, doesn't it?
It does, the diaphragm.
Yeah.
It's this large dome-shaped muscle. Well, it's muscle and fibrous tissue, really. It physically separates your chest cavity from your abdominal cavity below.
The floor of the chest, basically. And it's the main breathing muscle.
The main muscle for quiet respiration, yes. When you're just breathing normally, sitting relaxed.
And doesn't it have that great mnemonic for its nerve supply?
Ha, yes, everyone loves that one. The phrenic nerve controls its movement, and that nerve comes from spinal roots C3, C4, and C5. So
C3, 4, or 5 keep the diaphragm alive.
That's the one. When that nerve fires, the diaphragm contracts, flattens down.
Pulling air into the lungs.
Precisely. It increases the volume of your chest cavity, pressure drops, and air rushes in.
Okay, here's something I find fascinating. Hiccups. Are those related?
They are. Hiccups are essentially just involuntary, spasmodic contractions of the diaphragm. That little hic sound is the sudden closure of your vocal cords.
Huh. And what about that weird thing with shoulder pain?
Ah, yes, referred pain. This is clinically really important. If something irritates the diaphragm, like maybe inflammation underneath it,
You feel it somewhere else.
you can feel it as pain right at the tip of your shoulder. It seems strange, but it's because the phrenic nerve supplying the diaphragm, C3 to 5,
Shares the same spinal cord segments as the nerve supplying the skin over your shoulder.
exactly. Your brain gets a bit confused about the signal's origin. So diaphragm irritation can present as shoulder tip pain.
Wow. The body's wiring is just incredible.
Yeah.
Okay, one more key structure. The pleura. The lungs wrapper.
Yeah, think of it like cling film, but way more sophisticated. It's a serous membrane, very thin and smooth. It has 2 layers.
Who's theirs?
Yep. The visceral pleura sticks right onto the surface of each lung, following all its curves. Then there's the parietal pleura, which lines the inside of your chest wall, the diaphragm, and the mediastinum.
And there's a space between them.
A potential space, yes, the pleural cavity. Normally it just contains a tiny, tiny bit of serous fluid, like lubrication.
To let the lungs move smoothly.
Exactly. So the lungs can inflate and deflate without friction against the chest wall.
Now, I read something really interesting about the nerves here. Pain sensitivity is different.
Hugely different, and it's quite a clever design. The parietal pleura, the outer layer lining your chest wall, that's very sensitive. Pain, temperature, touch, it feels it all. It's supplied by the intercostal nerves and the phrenic nerve.
Okay.
But the visceral pleura, the layer right on the lung itself, it's supplied by the autonomic nervous system and is generally insensitive to pain.
Why the difference?
Well, think about it. You want to know if something is wrong with the chest wall or the space around the lung, like inflammation, right? That could be serious infection or injury.
Makes sense.
But you probably don't want to feel pain every single time your lung stretches and moves with each breath. The lung itself needs to function without constantly sending pain signals.
That is clever. So conditions like pleural effusion or a pneumothorax, they involve that pleural cavity?
Precisely. Pleural effusion is when excess fluid builds up in that pleural cavity, and pneumothorax is when air gets in there.
And that can collapse the lung?
It can, because the air breaks that seal and surface tension, and the lung's natural elasticity makes it recoil. If fluid needs removing, doctors perform a pleural tap, or thoracocentesis.
Right, draining the fluids. There's a specific spot they aim for.
Oh yes, very specific. Usually in the 7th, 8th, or maybe 9th intercostal space. The space between the ribs kind of midway around your side, what we call the mid-axillary line. Going lower risks hitting the diaphragm or liver, going elsewhere risks the lung itself.
It really paints a picture of such intricate design. We've gone from the central mediastinum to the powerhouse diaphragm to this sensitive pleural lining.
It's quite the tour, isn't it? Underneath the surface, it's this constant, elegant interplay of structures.
Absolutely. It really highlights how much of our well-being depends on these hidden parts working perfectly.
And you know, this incredible interconnectedness, this hidden world inside us, maybe it prompts a thought.
Yeah.
How else might your body be subtly communicating its needs?
Welcome to the Deep Dive. Ever stop to think about the sheer engineering marvel that happens every time you take a step? Probably not, right? We just walk. Well, today we're doing a deep dive, kind of a shortcut, into that amazing world inside your lower limbs. We're talking everything from the arches in your feet up to the hip, the knee, even the arteries, keeping it all going. Our goal, to pull out the really key stuff, maybe some surprising facts, and connect it all back to how you move and, yeah, sometimes how things get injured. Ready to jump in?
Let's do it. And we'll start right at the bottom with your feet, specifically the arches. These aren't just static bumps, you know, you've got the main ones, the medial and lateral longitudinal arches. They act like a dynamic spring system.
A spring system, how does that work?
Well, it's a mix of things. The way the bones fit together, sure, but also really strong ligaments. Think the plantar aponeurosis under your foot, the spring ligament, and then you have muscles like the tibialis anterior acting like active bowstrings holding everything up. It's quite clever.
Huh. Active bowstrings. I like that. So it's constantly working then. What happens if that system starts to fail?
Right. So if those ligaments and tendons get weak, maybe stretched out, the arches can literally collapse, and that's what most people call flat feet. The medical term is pes plenus.
Ah, okay. Pes plenus. And that changes how you absorb shock, I imagine.
Exactly. It throws off the whole weight distribution, shock absorption, can definitely cause problems further up the leg.
Makes sense.
Oh.
Okay, moving up then to the hip, the powerhouse you called it. It's a ball and socket joint, right? Femur head fitting into the hip bone socket.
That's the one. A synovial joint, so it's got fluid in there keeping things smooth. But the real story is its strength. A huge part of that comes down to one specific ligament, the iliofemoral ligament. People often call it the Y ligament of Bigelow.
The Y ligament, why is it so special?
Because it's believed to be the strongest ligament in your entire body.
Wow. Strongest.
Yeah. Its main job is stopping your hip from hyperextending, going too far backward. It's a massive anchor, basically, letting your hip handle huge forces. There are others too, like the pubofemoral and ischiofemoral, that help control other movements, like swinging your leg out too far or rotating it inwards too much.
Okay, so super strong, but not invincible, I guess. What kind of problems do hips run into?
Well, dislocations can happen often backwards, like in a car crash, the classic dashboard injury where the knee hits the dash and forces the femur back. And then especially in older adults, fractures of the femoral neck, the sort of thin part just below the ball, are a big concern.
Why is that type of fracture so serious?
The big worry there is the blood supply. A bad fracture can easily damage the arteries feeding the head of the femur.
Yeah.
If that happens, you risk a vascular necrosis. Basically, the bone tissue dies from lack of blood. It's really debilitating.
Okay, let's shift focus to the knee. You described it as a complex hinge.
Yeah, a hinge joint, mainly. It's where the femur and tibia meet with the patella, your kneecap, involved too. But it's got this really neat trick.
A trick.
A locking mechanism. When you fully straighten your leg, the femur does a tiny rotation inwards on the tibia. This makes the knee super stable, so you can stand for ages without using much muscle power. It sort of locks into place.
Energy saving.
Yeah.
So how do you unlock it to bend your knee again?
There's a small muscle behind the knee, the popliteus. Its job is basically to initiate that unlocking rotation, allowing flexion to start. Pretty cool, huh?
Very cool. But knees take a beating, right? Especially with twisting motions. What about the ligaments inside?
Absolutely crucial. You've got the cruciate ligaments deep inside the ACL and PCL. They stop the tibia sliding too far forward or backward under the femur. And then on the sides, you have the collateral ligaments, MCL medially, LCL laterally. They provide side-to-side stability.
Right. And isn't there that injury, the terrible triad? What's involved there?
Yes. The classic, unfortunately. That involves tearing the ACL, the MCL, and the medial meniscus. That's one of the cartilage shock absorbers inside the knee. The reason the medial meniscus often goes with the MCL is because they're actually attached. So when the MCL tears from a blow to the outside of the knee, it often takes the meniscus with it.
Ouch. Okay, finally, let's talk lifelines. The artery supplying all this, the femoral artery is the big one in the thigh.
That's right. It's basically a continuation of the external iliac artery from your abdomen, starting right around the groin crease at the inguinal ligament. It runs down through an area called the femoral triangle.
And you can feel the pulse there.
Yep, pretty easily usually, right in that triangle. It's a key pulse point.
Yeah.
But unfortunately, it's also a really common spot for atherosclerosis.
That hardening of the arteries.
Exactly, which leads to peripheral arterial disease, or PA. Poor blood flow to the legs. Then, as the femoral artery goes down, it ducts behind the knee through that hollow space called the popliteal fossa. There, it becomes the popliteal artery.
Popliteal fossa. And can you feel that pulse too?
You can, yeah, but it's deeper, trickier. Usually helps to bend the knee a bit. A major concern back there is a popliteal aneurysm where the artery wall balloons out. If it gets big, it can actually press on the tibial nerve running nearby and cause quite a bit of pain or numbness.
Wow. Okay, so from the springy arches to the super strong hip, the clever locking knee, and these vital arteries, it really is an incredible system.
It absolutely is. Just this silent orchestra of parts working together constantly beneath the surface.
So next time you're just walking around, maybe think about that complex choreography happening inside your legs. What simple thing that you do every day suddenly seems a bit more amazing when you consider all that anatomy. Something to ponder. Thanks for joining us on this deep dive.
Welcome to the deep dive. Ever just stop and think about the incredible engineering that happens with every single step you take?
It's wild, isn't it?
Yeah.
So much going on under the surface. Completely automatic most of the time.
Exactly. So for this deep dive, we wanted to give you a kind of shortcut to understanding that whole complex world of your lower limbs.
Right. We're talking everything from, the arches in your feet all the way up to the hip, the knee.
In the arteries, keeping it all going. Yeah. Our goal is really just to pull out the key bits of info, maybe some surprising facts, and connect it all back to actual movement and common injuries.
Okay, let's start right at the bottom then. Your foundation. The foot arches.
The arches, right.
Yeah, you've got the main ones, the medial and lateral longitudinal arches. And what's really cool isn't just the bones fitting together. It's this dynamic support system. You've got strong ligaments like the plantar aponeurosis, the spring ligament, and then muscles like tibialis anterior acting almost like bowstrings. They create this tension.
Bowstrings, that's a great image. So they're constantly adjusting to support you.
Pretty much, yeah. Absorbing shock, adapting to surfaces.
So what happens when those bowstrings or ligaments weaken? Is that flat feet?
That's basically it, yeah. Pes planus. If those supports lose their tension, the arch can collapse. And that changes, everything about how your foot hits the ground.
Right, and that could cause problems further up the leg, I imagine.
Definitely. Okay, so moving up from the foot, we hit the powerhouse. The hip joint.
The hip, big joint.
Huge. It's a synovial ball and socket. You've got the head of your femur fitting into the acetabulum in your pelvis, built for strength and movement.
And I hear it has some serious protection, like really strong ligaments.
Oh, yeah. The standout is the iliofemoral ligament. Some people call it the Y ligament of Bigelow.
Yeah, ligament.
And it's actually the strongest ligament in the entire human body.
Wow. Strongest. What does it do?
Its main job is stopping your leg from going too far backward. preventing hyperextension.
Okay. But even with the strongest ligament, hips still get injured.
They do. Hip dislocations, often backwards. You see those sometimes in like dashboard injuries from car crashes.
Ouch.
And then, especially in older folks, femoral neck fractures are a big concern.
Because of the blood supply.
Exactly. Breaking the neck of the femur can cut off blood to the femoral head. That can lead to something called the vascular necrosis. Basically, the bone tissue dies. Not good.
Definitely not. Okay, from the powerhouse hip down to the complex knee, you called it a hinge.
Well, it's often called a hinge joint, yeah. Synovial joint, where the femur meets the tibia with the patella, your kneecap, out front. But it's way more clever than a simple door hinge.
How so?
It has this amazing locking mechanism. When you fully straighten your leg, your femur rotates just slightly on the tibia, and it locks the knee.
So it's stable without much muscle effort.
Exactly. Super efficient for standing. Then, to bend your knee, you need to unlock it.
How does that happen?
There's a small muscle called the popliteus, back of the knee. It does a little rotational twist to unlock the joint so you can start flexing.
That's brilliant. And ligaments hold it all together.
Absolutely critical. You've got the cruciate ligaments, the ACL and PCL, inside the joint, stopping the tibia sliding forward or back.
Right, the famous ACL.
And then the collateral ligaments, MCL and LCL, on the sides, providing that side-to-side stability.
Okay, so lots of moving parts, lots of ligaments. What about that really nasty injury, the terrible triad?
Ah, yes, the unhappy triad.
Yeah.
That typically involves tearing the ACL, the MCL, and the medial meniscus. That's the cartilage disc on the inner side of the knee.
Why the medial meniscus specifically?
Because it's actually attached firmly to the MCL.
Yeah.
So when the MCL gets hit hard and stretches or tears, it often takes the medial meniscus with it.
Gotcha. Okay, makes sense. No, none of this works without blood supply, right? The lifelines.
The arteries, yeah. Crucial. The main highway in the thigh is the femoral artery.
Femoral artery, where does that run?
It's basically a continuation of the external iliac artery from your abdomen. It starts up near the inguinal ligament in the groin area, runs down the thigh.
And you can feel the pulse there.
Yep, quite easily in what's called the femoral triangle, high up in the inner thigh. It's a key pulse point.
Useful. Any downsides to it being there?
Well, unfortunately, it's a really common spot for atherosclerosis.
Plaque buildup.
Yeah, hardening of the arteries. That can lead to peripheral arterial disease, causing pain when walking.
Okay. And does that artery continue down past the knee?
It does. Once it passes through an opening in the adductor magnus muscle, it goes behind the knee, and its name changes to the popliteal artery.
Popliteal. That sounds harder to find.
It is. It's deep in the popliteal fossa, the space behind your knee. You can usually feel the popliteal pulse best if the knee is bent a bit, relaxes the muscles.
Any specific problems back there?
A big concern is a popliteal aneurysm, like a bulge or ballooning in the artery wall.
And that's bad because...
It can compress the tibial nerve, which runs right nearby. That can cause pain, numbness, tingling down the leg or foot.
Wow. So, okay, we've gone from the intricate arches of the foot through the super strong hip, the clever locking knee, and traced the vital arteries. It really is an incredible system.
Absolutely incredible. The way it all interconnects and functions is just, well, elegant design.
So next time you stand up, walk, or even just wiggle your toes, maybe take a second.
Consider that silent, complex orchestra bones, ligaments, muscles, vessels, all working together beneath the surface.
What simple daily action suddenly seems extraordinary when you really think about the anatomy behind it? Something to ponder until our next deep dive. Welcome. We're doing a deep dive today into the anatomy down in your lower limbs, specifically looking at the veins and nerves, the real foundational stuff. Our goal, to give you the key takeaways, fast, a bit of a shortcut to understanding these complex systems.
Exactly. And understanding this, it's not just theory, it gives you real practical insights into, well, your everyday comfort and movement. We'll try and connect the definitions to what they actually mean for you day to day.
Okay, let's jump right in. Varicose veins. Most people know the name, but what's actually going on under the skin?
Right, so varicose veins are basically superficial veins, usually in the leg, that have become swollen, kind of twisted. The main issue is what we call incompetent valves.
Valves, like little gates.
Yeah, precisely. Tiny one-way gates inside the veins meant to keep blood flowing back up to the heart. When these gates fail, blood starts to pool backwards. That's what causes the swelling.
And what makes them fail? Is it just bad luck?
Well, genetics definitely play a role, but also things like standing for long periods, pregnancy, even obesity can predispose you.
Okay, so blood pooling because the valves aren't working. what's the biggest worry if they're left untreated? Is it just how they look?
It can become more serious than just aesthetics. If that blood flow stays poor for a long time, chronic insufficiency, we call it Grana, it can actually damage the surrounding tissue.
Damage how?
It can lead to varicose ulcers. These are sores, often quite stubborn ones, that typically show up just above the inner ankle bone, the medial malleolus.
Ulcers. Okay, that sounds pretty serious, not just cosmetic at all. Right, let's pivot then. From plumbing to wiring the nerve system, in the lower limbs, there's one nerve that seems to get all the attention, isn't there? The big one.
You're absolutely right. That would be the sciatic nerve. And it really is big. Literally the largest nerve in the entire body.
Wow. Where does it run?
It originates from the lower spine, nerve roots L4 down to S3. Then it travels down the back of the thigh. It directly supplies the hamstring muscles. And then through its branches, it powers, well, all the muscles in the lower leg and the foot. Everything below the knee, basically.
Okay, so huge nerve, huge territory. But it's also known for causing problems, right? Clinically speaking.
Oh, yes. Very common issues. Injury or irritation causes sciatica. That's that shooting pain, often quite intense, that radiates down the leg, follows the nerve's path.
I think many people have heard of sciatica. What else?
Well, a specific branch of the sciatic, the common fibular nerve, if that gets damaged, it leads to foot drop.
Foot drop, what does that look like?
It means you physically can't lift the front part of your foot upwards, dorsiflexion it's called. So to walk without tripping, you have to lift your knee much higher than usual with each step. It's a very distinct high steppage gait, like you're stepping over something.
Got it. A very clear sign something's wrong with that nerve branch. But the sciatic isn't working alone down there, is it? What other nerves are crucial for movement?
No, definitely not alone. Another major player is the femoral nerve that comes from L2 to L4. This one powers the quadriceps muscles at the front of your thigh, the ones that straighten your knee.
So if that's injured,
your knee extension is knocked out. Your knee can just buckle unexpectedly because the main muscle group for straightening it isn't getting the signal.
Okay. And there's another one from that same L2, L4 region.
Yes, the obturator nerve. This one handles the adductor muscles on the inside of your thigh.
Adductors. Pulling the legs together.
Exactly. So damage here weakens that movement, which can affect your gait, make it feel unstable, and sometimes cause pain in the inner thigh.
Right. So we have nerves for extending the knee, bringing legs together. What about hip stability? Holding everything steady when we stand or walk?
That's mainly the job of the superior gluteal nerve. It comes from L4 to S1. It supplies two key muscles on the side of your hip, gluteus medius and gluteus minimus.
And they do what exactly?
They're crucial for hip abduction, moving your legs straight out to the side. And, really importantly, they stabilize your pelvis when you're standing on one leg.
So what happens if that nerve is weak?
You see something called a positive Trendelenburg sign. When you ask someone to stand on the leg with the weak nerve, the other side of their pelvis, the unaffected side, will actually drop down.
The opposite side drops?
Yes, because the muscles on the standing side can't hold the pelvis level. It leads to this characteristic sort of waddling gait as the body tries to compensate for that instability.
Wow. Okay, so from tiny failing valves in our veins to these incredibly specific nerve pathways controlling every little movement, we've really covered how intricate the design of our lower limbs is and also how things can go wrong.
Absolutely. And if you think about the big picture, you hopefully have a clearer sense now of how these, quite specific structures really dictate your everyday mobility, your balance, how comfortable you feel just standing or walking. It all links back.
It really makes you appreciate the complexity. So as you're moving around today, maybe walking, maybe just shifting your weight, think about that delicate balance, that whole network of veins and nerves working underneath it all. What detail about how your own body works stands out to you now? Something to maybe ponder on your next walk.
Welcome to this deep dive. Today we're really going to crack open your sources on core abdominal anatomy.
Yeah, looking forward to it.
Our goal is to quickly get you those key insights, maybe some surprising connections, and, the clinical details that actually matter.
Those aha moments, right?
Exactly. So let's start with, a shape that seems simple but isn't. The C-shaped duodenum. It really sets the stage.
It really does.
Okay, so let's unpack this. Looking at the sources, what jumps out is how this C shape of the duodenum, the first 25 centimeters of the small intestine It's not random.
Not at all.
It's like this perfect cradle, right? The head of the pancreas is just nestled right inside that curve.
It's a really intimate relationship and functionally profound too. The pancreas itself, it's this amazing mixed gland.
Mixed how?
Well, if you've got the exocrine part, the pancreatic catena making all these digestive enzymes, powerful stuff.
Right.
And then the endocrine side, the islets of Langerhans, they're busy making hormones, insulin, glucagon, vital.
But that closeness, that embrace, it creates vulnerabilities too, doesn't it?
Absolutely. That's the trade-off.
Your sources really highlight duodenal ulcers. Especially in that first part. They can actually erode.
Right into the gastroduodenal artery. Yeah.
Which runs right behind there. And that's not just a small bleed.
No, that could be catastrophic. Really severe hemorrhage.
And this connection, it explains other things too.
Definitely. If we zoom out slightly, you see congenital issues like annular pancreas.
Where the pancreas forms a ring.
Exactly, a ring around the duodenum. It can squeeze it, cause obstruction. It's rare, but it happens because of that developmental closeness.
Wow.
And then within the pancreas, you have things like pancreatitis inflammation, where it can basically start digesting itself. Or pancreatic cancer.
Often in the head, right? Where it's nestled.
Precisely. And because it's right there, it can easily compress the bile duct, block it off.
Leading to that yellowing, the jaundice.
Obstructive jaundice, yeah. It's all connected.
Okay, let's shift gears a bit. From those internal organs to the abdominal wall itself. The inguinal canal.
Ah, another fascinating structure.
What struck me from the sources was the design, the sort of shutter mechanism.
Yeah, it's clever. The way the muscles work together, almost like a sphincter, to close it off when pressure increases.
Like a natural defense against bulging. So how does it fail then? Because inguinal hernias are pretty common.
Well, that fortress, as you called it, has potential weak points. The key is how things get through.
Okay.
An indirect hernia follows sort of a pre-existing path, the one the testes took during development, entering through the deep inguinal ring.
So it goes through the canal's entrance.
Right. Whereas a direct hernia is more brute force. It just pushes directly through a weakened spot in the back wall of the canal itself.
Ah, okay. Different routes for the breach.
Exactly. Now, thinking about movement and supply, the big pipelines.
Right, the abdominal aorta. Huge vessel. It continues down from the chest, doesn't it?
Yep. Starts around T12, goes down to about L4 where it splits, and along the way.
It gives off all those major branches. Celiac trunk, the SMA, the renals, the IMA.
Crucial supplies to almost everything in the abdomen and pelvis. It's the main highway.
But highways can have problems, like aneurysms.
That's a big one. An abdominal aortic aneurysm, or AAA, it's like a ballooning, a weak spot in the aorta's wall.
And the danger is?
Rupture. Often they're asymptomatic, you don't know it's there, but if it ruptures, it's a massive internal bleed, a true emergency.
Okay, and then there's the other major vessel, but it's different. The portal vein.
Ah, yes. Very unique. It doesn't just take blood back to the heart like most veins.
It's formed by other veins joining up.
Right, the superior mesenteric vein and the splenic vein primarily. It collects all this nutrient-rich, but maybe toxin-filled blood from the gut, spleen, pancreas.
And takes it where?
To the liver. It's like a detour for processing. The liver cleans it up, metabolizes nutrients before that blood goes into general circulation.
A built-in milter. Clever.
Very. Yeah. But again, vulnerabilities if pressure builds up in that system.
Portal hypertension. Yeah. Often from liver disease like cirrhosis.
Exactly. The liver gets stiff, blood backs up in the portal vein, and that pressure has to go somewhere.
So it finds other routes.
It does. It forces open tiny connections, leading to things like esophageal varices, which can bleed dangerously. Or sometimes you see it visibly.
That caput medusae.
Yeah, those dilated veins snaking out from around the belly button. A pretty dramatic sign of that high internal pressure.
So, pulling this all together,
yeah.
What does this deep dive really show us, based on your sources?
Well, I think it shows incredible interconnectivity, how anatomy isn't just structures in isolation.
Right. That nestled pancreas, the shutter mechanism, the portal detour, it's all about relationships and function.
And also vulnerability. These elegant designs often come with inherent weaknesses. It's a system of compromises, really.
What's strong in one way can be weak in another.
Precisely. A structural advantage can become a critical flaw under certain conditions.
So for you, listening, hopefully this shows how just understanding a basic anatomical fact, like a shape or connection, it can unlock really deep insights into both how the body works so well and how things can go wrong. Health and disease.
It makes you appreciate the complexity.
Definitely. So maybe consider this. What other anatomical relationships, things that seem mundane, might hold their own secret stories? Stories of both, amazing efficiency and hidden danger. Something to think about. Welcome to a deep dive into some surprising anatomical clues. We're looking at your body's hidden vulnerabilities today.
Yeah, straight from your anatomy paper too. Rapid revision notes.
Exactly. We're going to explore 4 key organs: the liver, stomach, appendix, and spleen, and really unlock some, unexpected insights.
Our goal is basically to connect the dots, Between the anatomy, you can see the micro stuff happening inside and what it all means clinically.
Should lead to some aha moments, I think.
Definitely. Think your internal processing plant, immune hub. Lots going on.
Okay, let's start with the liver then, the big one. Tucked up there in the right upper abdomen.
Right.
Beyond just its size, what's anatomically speaking really unique about it, something that explains its huge role in body chemistry.
Well, the big thing really is its dual blood supply. It's quite fascinating.
Dual supply, how does that work?
Okay, so think of it like this internal customs office, right? It gets the normal oxygenated blood through the hepatic artery, like other organs. Exactly. But then, maybe 75%, a huge chunk, comes via the portal vein. And that blood is deoxygenated but packed with nutrients. And maybe toxins, straight from your gut.
Okay. So it gets first dibs on everything absorbed.
Pretty much. That's what lets it be the primary filter, the metabolic powerhouse, the detox center. Nothing else quite does that.
So it's constantly processing everything. And I suppose when that filter gets damaged, like with cirrhosis, that irreversible scarring, that dual supply must become even more critical.
Absolutely. I mean, the liver can regenerate, famously so, but cirrhosis is where the damage it overwhelms that ability.
Yeah, a reminder of how vital that whole system is.
Definitely.
Okay, moving on from the liver, let's talk about the stomach. J-shaped, we know digestion, obviously.
Yeah, right.
But your notes mention this really rich blood supply, all coming off the celiac trunk. Why is that specific detail, that robust supply, so important clinically?
That's a great question. So the celiac trunk is like a main highway for blood to your upper abdominal organs. The stomach gets a lot from it. And here's where it gets clinically relevant. Peptic ulcers. If one of those erodes deep enough into a major artery nearby,
You get major bleeding.
you can get severe life-threatening bleeding.
Yeah.
And another thing kind of surprising,
Go on.
this thing called Virchow's node. It's an enlarged lymph node way up in your left collarbone area.
In the neck. What's that got to do with the stomach?
Well, it can actually be a sign of advanced stomach cancer that's spread. It's like this distant alarm bell.
Wow. That's quite a connection. A sign in your neck for a problem way down in your stomach.
It shows how things are linked, doesn't it?
Definitely. Okay, let's zoom in now. Smaller player. The appendix. That little finger-like thing off the start of the large intestine.
Cecum, yeah.
Often misunderstood. Is there a specific anatomical landmark that helps doctors pinpoint trouble, like appendicitis?
Oh, absolutely. McBurney's Point. Crucial landmark.
McBurney's Point. Where's that?
It's a specific spot on your lower right abdomen. In classic acute appendicitis, the pain often starts vaguely, maybe around the belly button, but then, as the inflammation worsens and irritates the lining of the abdomen, the pain shifts and becomes really sharp, right at McBurney's Point. Maximum tenderness there.
So that tiny little organ makes its presence known very specifically.
Very specifically. No mistaking it when it happens.
Right. Okay, last one. The spleen. Largest lymphoid organ. It's kind of tucked away deep behind the ribs on the left side.
Yep, deep to ribs 9, 10, and 11. It's got lots of important neighbors: stomach, pancreas, kidney.
Seems pretty protected then. But is there a catch? A vulnerability?
There is, and it's important. Despite that location, its outer capsule is quite thin, actually. Fragile.
So not as tough as it looks.
Not really, which means blunt trauma to the abdomen or even fractures of those overlying ribs can rupture the spleen. And because it's so full of blood, a rupture carries a really high risk of severe internal bleeding.
So it's doing vital work, filtering blood in its red pulp, handling immune responses in its white pulp.
Exactly, like a combined filter and immune command center.
But it's surprisingly delicate. Sort of a glass cannon.
That's a good way to put it, yeah. Vital but vulnerable.
Okay, so from the liver's unique dual plumbing to the stomach's distant warning sign, the appendix's pinpoint pain, and the spleen's fragile nature, These anatomical details really matter clinically, don't they?
They absolutely do. So, thinking about what this means for you, the listener, understanding these points isn't just like academic trivia.
Right.
It gives you real insight into how your body is designed, its incredible capabilities, but also where things can, go wrong. Virchow's node, McBurney's point, they tell stories.
Yeah, stories about health and disease. Your body really is this marvel of engineering, just full of these hidden clues. Makes you wonder what other connections are waiting there if you just look a bit closer at the anatomy. Ever wondered how a doctor can, figure out so much from what seems like a simple exam? Or why certain pains hit us in such specific ways? Today, we're taking a deep dive into the human male pelvis and urogenital tract. Our sources are these rapid revision notes, kind of like an anatomical cheat sheet, really. Most is cut straight to the important stuff.
Exactly. And our job here is to pull out those really interesting nuggets, show the clever logic, maybe sometimes the vulnerable spots in how we're built, and connect it all so it makes sense in the real world for you.
Okay, let's unpack this. Maybe start with an area people think is just, the end of the line, the rectum.
Mm-hmm.
But what's really surprising is how useful it is for diagnosis. Like, a digital rectal exam lets doctors feel the prostate in men, or even the cervix in women, like a little window.
It really is a keyhole view into nearby structures. And think about something common like hemorrhoids. People often just say varicose veins. But anatomically, there's this key dividing line, the pectinate line. Internal ones above the line are different from external ones below it. Different nerves, different sensations, different treatments.
So that line is crucial.
Absolutely. It's a precise marker guiding what doctors do.
Okay, from that diagnostic gateway, let's shift to the body's filtration system. The kidneys and ureters, paired organs, bean-shaped, constantly cleaning our blood. And here's a fun fact. The right kidney sits a bit lower than the left one.
Yeah, slightly lower, usually because of the liver pushing it down. Seems small, but it shows things aren't perfectly symmetrical inside.
Right.
And that hints at hidden complexities. When things go wrong, like with kidney stones, the pain location is very, very specific. Stones often get stuck at 3 main bottlenecks in the ureter.
Okay, where are those?
First, right where the ureter leaves the kidney, that's the pelviuretic junction. Second, where it crosses over those big iliac blood vessels. And third, just as it enters the bladder wall, the ureterovesical junction.
So knowing those exact spots is key.
Crucial for understanding the pain, obviously, but also for procedures. Like a kidney biopsy, you absolutely need to know where those junctions are to avoid, say, puncturing the lung lining, the pleura.
Makes sense. So from filtration, let's move to some male-specific structures. Male urethra, for instance. It's not just a simple pipe, is it? It's pretty long, about 20 centimeters, and has 3 different sections.
That's right, prostatic, membranous, and spongy, and it carries both urine and semen.
So that complexity matters.
Definitely. It explains why something like catheterization needs real care. You have to know the curves to avoid causing injury.
And this connects to the scrotum too, right? Which is also more complex than it looks.
Much more. It's not just a sac. It's got, believe it or not, 7 distinct layers protecting the testes inside. And those tests are working away, producing sperm and testosterone.
And this is where development comes in, clinically speaking. Things like cryptorchidism.
Yes, the undescended testes. That's not just a minor issue.
It increases risks, right?
Significantly. Higher risk of infertility and, importantly, testicular cancer, if it isn't corrected, shows how early development matters long-term.
Wow. Right.
And that actually leads nicely to another condition. You ever hear the term bag of worms?
Yeah, I have. For varicocele.
Exactly. It describes the look and feel of enlarged veins in the spermatic cord. And what's anatomically interesting is it's much more common on the left side.
Why is that?
It's plumbing, essentially. The left testicular vein joins the left renal vein at a sharp, sort of right angle. That makes backflow more likely compared to the right side, which drains more directly into the big vena cava vein.
So a small anatomical detail explains a common clinical finding.
Precisely. And just quickly, on the topic of pain down there, testicular torsion, that's a real emergency.
Where the cord twists.
Right, cutting off blood supply. Needs immediate medical help. Shows how vulnerable these structures can be. So what we've kind of walked through today really shows that understanding these, nuts and bolts isn't just academic. It reveals the logic, the brilliant design, and sometimes the weak points behind diagnoses, common problems, and even surgeries. Gives you a real appreciation for it.
Yeah, absolutely. So what does this all mean for you listening? Well, next time you hear about a condition in these areas, maybe think about those hidden anatomical details, the precise locations that dictate everything from symptoms to treatment. It's not just what's wrong, but why it's wrong in that specific anatomical way. It makes you wonder, what other simple body parts are holding surprising secrets? Welcome back to the Deep Dive. We're taking your rapid revision notes today and really digging into the human body's structure, trying to make sense of some key anatomy fast.
Yeah, and not just what things are, but why they're built that way, and crucially, what can go wrong. It tells you a lot.
Okay, so let's start with something, well, maybe a bit hidden, but important. The inguinal canal.
Ah, yes.
Just 4 centimeters in the lower abdomen. What's it actually for?
Well, it's essentially a necessary passageway. Think of it like a tunnel.
Okay.
It lets structures pass from the abdomen down towards the external genitalia, so the spermatic cord in males,
Right.
and the round ligament of the uterus in females.
And it has protections. You mentioned a mechanism.
It does, yeah. There's a kind of shutter mechanism where muscle contractions sort of pinch it closed when abdominal pressure increases, acts a bit like a sphincter.
But it's still a weak spot.
It is. It's an inherent vulnerability, really, which leads us to, well, inguinal hernias.
The common problem there. And there are different kinds, right?
Exactly. 2 main types you hear about. There's indirect,
Okay.
which is the most common, often congenital, meaning it's there from development. Contents push through the deep inguinal ring,
The entrance.
right, lateral to some key blood vessels, the inferior epigastric ones. Then you have the direct hernia.
And that's different how?
That's usually acquired, happens more in, say, older men. The contents push directly through a weakened spot in the back wall of the canal.
Medial to those same vessels.
Precisely. Different paths, same problem. Pressure finding a way out.
Okay, moving on. Let's talk about the rectum. Terminal part of the large intestine.
Right. Follows the curve of the sacrum there at the back.
And its position relative to other organs is key.
Very much so. In males, you've got the bladder and seminal vesicles just in front, separated by the rectovesical pouch.
Okay.
In females, it's the uterus and vagina in front, separated by the rectuterine pouch, the pouch of Douglas.
And that matters for exams.
Absolutely. A digital rectal exam lets a doctor feel the prostate through the rectal wall in men.
Or the cervix in women.
Exactly. And while we're there, hemorrhoids are a common issue, basically varicose veins.
Right. And the pain depends on location.
Yeah. Whether they're above or below the pectinate line, that line marks a change in nerve supply, so below it tends to be much more painful.
Fascinating detail. Okay, let's shift to a major joint, the hip. Ball and socket, known for being stable.
Extremely stable. It's got some seriously strong ligaments holding it together.
Like the main one.
The iliofemoral ligament, yeah. Often called the Y ligament of Bigelow. It's actually the strongest ligament in your entire body.
Wow. And its job.
Primarily prevents hyperextension, stops your thigh going too far back. Then you've got the pubofemoral, which limits abduction, moving the leg out. And the ischiofemoral, which checks medial rotation, turning the leg inward.
But even strong joints have weak points.
They do. Severe trauma, think car crash, dashboard hitting the knee,
Oh, right.
can cause a posterior hip dislocation. The ball pocks out backwards. And in older people, especially with osteoporosis, brittle bones, yeah, the femoral neck, the part just below the ball can fracture easily. That's dangerous because it can cut off blood supply to the head of the femur.
Serious stuff.
Oh,
Okay, let's touch on the pelvic floor area. The ischiorectal fossa. Sounds obscure.
it does a bit. It's basically a wedge-shaped space on either side of the anal canal, and it's filled with fat.
Fat? Why?
Well, that fat padding allows the anal canal to expand easily during defecation. It needs that flexibility.
Makes sense. But there's a downside.
The downside is that this fatty tissue doesn't resist infection well. So perineal abscesses, which are nasty infections down there, can spread really easily through this fossa. Turns that flexible space into a potential pathway for infection.
A trade-off again. And connecting to that area, let's talk uterine support.
Right, the uterus, pear-shaped muscular organ, it relies heavily on support structures to stay in place.
What kind of structures?
Think ligaments acting like internal guy ropes. You've got the cardinal ligaments providing side-to-side support, the uterosacral ligaments pulling back towards the sacrum.
Keeping it tilted correctly.
Exactly. Plus the round ligaments and, importantly, the muscles of the pelvic floor itself. It's a whole system.
And if that system weakens,
Then you can get uterine prolapse. The uterus basically slips down from its normal position. Childbirth, age, they can weaken the support.
leading sometimes to procedures like hysterectomy.
That can be a solution for severe cases, yes. Restoring function and comfort.
It's truly incredible, isn't it, how all these different parts, the canals, joints, ligaments, muscles, they all work together.
They really do. Intricate designs.
From hidden passages to major joints, it shapes so much of our daily life and potential health issues.
Absolutely. And maybe the thought to leave you with is this. Seeing how interconnected everything is, how resilience is built in, but also these specific vulnerabilities. What does that make you think about the sheer complexity and, well, the wonder of your own body?